Hello everybody. Today we are going to discuss about hyperosmolar hyperglycemic syndrome. So we have this 72-year-old male patient who is a known case of diabetes mellitus, ILD, post-PTCA2, LCX and LM. Now came with chief complaint of reduced appetite, generalized weakness and decreased oral intake. When he came to ER, his blood sugar was 900. So they have started him on the HI infusion. ABG was taken, which was bang normal, and the sodium was 161. So this was the ABG of the patient, and this was the chest X-ray. So since the sodium level were high, we and his blood sugar levels were also high. So we need to calculate the corrected sodium here. The formula for the corrected sodium is measured sodium plus 1.6 into glucose in mg minus 100 upon 100. So according to this formula, his corrected sodium was 171. So to replace fluid, we have calculate the fluid deficit. So for calculating fluid deficit, we have used the following formula, that is percentage of the total body water into weight into current sodium upon ideal sodium minus 1. So according to this corrected sodium, the total amount of the fluid that need to be replaced was 10 liter. So how we have managed this patient? So we kept this HGT. We have started the insulin infusion to keep the blood sugar levels to maintain the blood sugar level. And once the blood sugar levels have become less than 250, we have stopped the infusion. And to replace the adequate amount of the fluid, we have started with D5, that is 100 ml per hour, ringer lactate 100 ml per hour, and then RT we have inserted, and through RT we have given fluid by 100 ml per hour of rate, with the 100 ml per hour of rate. Along with that, we have started him on the antibiotics and the DVT prophylaxis. So after 24 hours, his sodium levels were now 139. So now we will have brief discussion about hyperglycemic hyperosmolar coma. Severe hyperglycemia, dehydration, and coma have long been known to occur in the absence of significant acidosis and ketonemia among older patients with the diabetes. And the syndrome is designed as HHS. So mortality with the HHS has historically been high and in order of approximately 50%. But increasing recognition and improved ICU-based treatment have substantially improved this figure, and mortality more recently is on the order of 15%. The syndrome can be initially presentation of type 2 diabetes mellitus, and in United States it may occur with disproportionate frequency among African American youth. Now regarding pathophysiology and etiology, the pathophysiology that give rise to HHS require three interrelated elements to be present, that is insulin deficiency, renal impairment and the cognitive impairment. Now the first one is insulin deficiency. The relative insulin deficiency is the fundamental defect in the HHS. So patient have sufficient insulin to keep the ketone body formation, but not enough to prevent hyperglucovonemia, glucogenolysis and gluconeogenesis. So the resulting hyperglycemia induces osmotic diuresis with resultant fluid and the electrolyte losses. So the data suggests that partial insulinization of the liver with HHS enables affected patient to metabolize free fatty acid and therefore avoid ketogenesis in the face of severe hyperglycemia. So additional data indicated that, however, the hepatic insulinization alone cannot account for the absence of ketosis in the HHS. Ketone bodies can be induced when the medium chain triglyceride, that is segmental HHS. The results suggest that patient with the HHS would produces the ketone despite hepatic insulinization if enough substrate in the form of free fatty acid were present. The resistance to ketosis must therefore depend on the limited ability of circulating free fatty acids. The low concentration of free fatty acid during HHS may be due to relatively low concentrations of lipotic hormone, including growth hormone and cortisol, and concentration of which are lower in HHS than in the DK. Another explanation is that hyperosmolarity itself inhibits the release of free fatty acid, and additional unidentified factor may play a role. So the next is renal impairment. Some degree of renal impairment accompanies all cases of HHS. Younger patients with diabetes have normal GFR, and even in the event of decay, they filtered enough glucose into urine to prevent extreme hyperglycemia. In contrast, typical patients with HHS are older. Their renal flow and the GFR are reduced, and they cannot readily excrete glucose load. So when they become hyperglycemic, the glucose is neither metabolized nor excreted. It remains into the extracellular fluid space. The resulting increase in osmolality together with decreased GFR causes the still less glucose to be excreted. It has been suggested that among children with the baseline normal renal function, extreme hyperglycemia may be precipitated by intake of large amount of sugary drink to compensate for urinary fluid loss. The underlying renal abnormality of the HHS may be prerenal, renal, and postrenal. And the common result is that affected patients are unable to compensate for hyperglycemia with osmotic diuresis. And the result is extremely high glucose concentration. Severe hyperglycemia itself can produce prerenal azotemia because glycosuria increases hypotonic osmotic diuresis, resulting in urinary loss of free water. If not replaced orally, these losses cause reduction in the intravascular volume and renal perfusion. The next component is the cerebral impairment. Hyperglycemia leading to hyperosmolarity normally activates thirst. The combination of mild diabetes and azotemia does not lead to HHS unless the affected individual does not drink sufficient water to prevent hyperosmolarity. Invariably, HHS involves acute or chronic impairment of cerebral function. Common history involves elderly patients with impaired cognitive function due to cerebral vascular disease, dementia, or cerebral nervous system, depressant medication. The impairment may involve either concurrent impairment of normal thirst mechanism or inability to respond thirst due to speech or motor deficit. Patients with trauma or burns have large insensible water losses and often unable to drink and are susceptible to HHS in the absence of adequate parenteral fluids. Animal studies confirm that fluid restriction is necessary to produce an HHS-like disorder. Decreased thirst leads to increased dehydration, increased stupor, and further decreases the fluid intake. Other factors such as angiotensin may also be involved. Now, regarding to summarize, the three interrelated factors are required for HHS. Insulin deficiency leads to hyperglycemia and glycosuria. Impaired renal function exaggerate hyperglycemia leads to hyperosmolarity. And decreased free water intake precludes the dilutional compensation and further exacerbate prerenal azotemia. Together, these three factors produces the dehydration in the hyperosmolar hyperglycemic state. The severe dehydration that occur with this syndrome is due to osmotic diuresis of glucose in the absence of compensatory free water intake. So dehydration in turn lead to hemoconcentration, setting the stage for severe prerenal azotemia, thrombosis, and shock. As glucose and the osmolality rises, the cerebral function is progressively compromised. Coma ensures when the serum osmolality is 350, when HHS may take several days to develop. So the clinical findings in HHS, patients who develop HHS are typically middle-aged and elderly. Syndrome occurs less commonly among young patients and rarely among infants and may present overlap with the decay. Patients often have history of type 2 diabetes treated with diet and oral hypoglycemic agent. There may be a profound prodrome of the progressive polyuria, polydipsia, and occasionally polyphagia lasting days to several weeks. Most patients have underlying disease. Renal and cardiovascular disorder are most common. Other intercurrent problems including infection, myocardial infarction, stroke, hemorrhage, and trauma. Additional predisposing factors including dialysis, hyperelimination, and medications. Diazoxide, phenytoin, propranolol, immunosuppressive agents, cimetidine, antipsychotic drugs like clozapine, olanzapine all impair insulin secretion, their action, and have been implicated as causes of SHS. The disorder have been associated with the treatment of HIV with nucleoside analog didanosine and lithium-induced diabetes incidence. Fever is also common finding during HHS even in the absence of infection, but infection must be rigorously excluded for all cases. Patient may have hypotension and tachycardia due to dehydration, and they may frequently hyperventilate. Neurologic manifestation including tumors and the fasciculations. Then mental status ranges from the mild disorientation to obtundation and coma depending on the degree of abnormalities in osmolality and perfusion. Up to third patient with the HHS may cease and may in this group as misdiagnosed as having primary intracerebral disease. Once treatment has been instituted, neurological symptom may clear the rapidly. The hyperventilation may reflect lactic acidosis, a common complication of severe dehydration and hypotension. Rapid restoration of hyperglycemic patient does not always imply the ketosis. The key to diagnosis of HHS is demonstration of hyperglycemia, hyperosmolarity without significant ketosis. Now regarding blood glucose concentration in the HHS are generally higher than the DK. It is usually greater than the 600. Values can be as high as 2000. So, and regarding acetone, many patients with the HHS are not ketonemic. Serum acetone levels are usually normal and only slightly elevated, seldom exceeding dilution of 1:2. Occasionally, patients with the HHS develop severe intercurrent metabolic acidosis. In these extremely ill patients, severe hyperosmolar state may overlap with ketosis, but such cases are uncommon. Severe serum osmolarity of comatose patient is usually more than 350. It can be measured directly in the lab, but it is easily and quickly approximated from BUN, sodium, potassium, and glucose concentration. Regarding acid-base balance, most patients with HHS are only mildly acidotic. Serum bicarbonate concentration and pH are usually close to normal. The average pH is about 7.25 and the bicarb is typically more than or equal to 50. The acidemia most often represents either mild lactic acidosis and uremic acidosis. When significant anion gap is present, the other causes of acidosis should be considered. These include salicylate, methanol, and ethylene glycol injection. Now regarding renal function, as outlined above, renal function is always impaired among patients with HHS. And in addition to the pre-existing renal disease, the dehydration includes prerenal azotemia, and the ratio of BUN to creatinine is usually greater than 13:1. BUN creatinine should be replaced after treatment to determine the degree of intrinsic renal impairment. The serum sodium concentration during HHS is highly variable, ranging from 100 to 180. And hyponatremia may result from the dilutional effect of osmotically active glucose among patients with the high free water intake in the face of impaired renal function. As I mentioned in the previous equation, for each 100 mg increase in blood glucose in the excess of 100 mg per dl, serum sodium concentration falls to approximately 1.6. So when severe hypotonic fluid loss occur in the later stage of HHS, patient may become hypernatremic. Because sodium remains in the extracellular fluid compartment, this electrolyte should be followed to assess the state of hydration. Frequent calculation of corrected sodium need to be done to properly guide and choose the fluid and rate of rehydration. Serum potassium concentration during HHS is also variable and it may range from the 2.2 to 7.8. Hypokalemia requires the immediate potassium replacement. As mentioned later, the serum potassium concentration decrease after treatment with the insulin is begun. Hyperkalemia often respond to the fluid replacement and the improvement in the urine output. Patients with the HHS, like those in the DK, lost substantial quantities of the electrolytes. Regarding treatment, the best treatment for the HHS is prevention. The condition can be avoided by the periodic attention to the blood glucose control and mental status. Susceptible individuals are those with mildly impaired glucose metabolism. They are often elderly who live alone. They may be hospitalized in patients who have experienced trauma, undergone extensive surgery, and have been placed on the hyperelimination regime. They may also be the resident of the nursing home, although improvement in the care appear to have reduced this risk. Individual in all these settings can be at risk of hyperglycemia and hyperosmolality. When HHS does occur, continuous vigilance for monitoring the details of the patient's clinical progress at bedside is key to achieving the successful outcome. Regarding fluid replacement, patients with the HHS are without exception profoundly dehydrated. The primary emphasis is the volume repletion. Within first 2 hours, the 1 to 2 liter of 0.9% of saline should be given, with total of 6 to 8 liter during the first 12 hours. Normal saline is recommended even if hypernatremia is present to expand the extracellular fluid compartment rapidly. After initial volume expansion and restoration of the normotension, subsequent treatment for dehydration in this syndrome emphasizes the free water replacement. The osmotic diuresis of the glucose produces free water loss in the excess of solutes. The initial infusion of normal saline must never be overlooked. However, because it rapidly expands the extracellular compartment and helps reestablish adequate perfusion. The corrected serum sodium can be used to help decide whether to switch from 0.9% saline to 0.45 saline, and that should be made. The rate of fluid administration must be adjusted as appropriate to the patient's clinical status. Elderly patients with cardiovascular impairment may require less aggressive replacement. Now, regarding electrolyte, as soon as adequate urine flow has been established, the degree of hypokalemia is estimated. Potassium supplementation should be added to the intravenous fluid. During initial phase of the therapy, serum potassium concentration should be checked frequently and ECG monitored for the changes in morphology and rhythm. A sudden fall in the serum potassium concentration frequently accompanies the initiation of insulin therapy. Cardiac arrhythmias induced by hypokalemia may be irreversible, particularly among elderly. The potassium deficit of the HHS can be more than or equal to 5 ml equivalent per kg, but generally the magnitude of the loss is not as great as that has been encountered during decay. Now, the next treatment of line is insulin. Most patients with the HHS are more sensitive to insulin than the patient with the decay. In addition, the blood glucose concentration in the HHS can fall rapidly when urine output is re-established after volume expansion with the saline. The combination of insulin sensitivity and the glucose diuresis puts the patient with HHS at risk of sudden unexpected hypoglycemia. So the treatment with the insulin is essential but should be instituted with careful monitoring and only after fluid and electrolyte resuscitation is undergone. Continuous infusion with short-acting insulin is now standard but must be used with great caution. Insulin infusion protocol as discussed above for decay are appropriate and require close and consistent monitoring of the glucose level and rate of glucose changes in order to make appropriate change to the insulin infusion and prevent hypoglycemia. As emphasized repeatedly, the normalization of the glucose is not primary goal of treatment. Fluid and electrolyte resuscitation may precedence and often improve glycemia substantially before any insulin is given. An attempt should be made to maintain the blood glucose concentration near 250 mg for first 24 hours. Rapid fall in the blood glucose concentration correlate with the development of cerebral edema. Now, regarding complication, the hypotension. When insulin is administered to patient with HHS, glucose shift from the extracellular to intracellular compartment. So because the glucose is osmotically active, the movement of glucose intracellularly draws free water from extracellular compartment. The rapid intracellular movement of the free water compromises the intracellular volume and may precipitate hypotension and shock. The use of normal, that is 0.9% saline for initial volume replacement help to prevent hypotension. The higher osmolality of the normal compared to the half normal saline reduce osmotic effect of the glucose shift that follow insulin administration. The magnitude of the fluid shift can be induced by insulin was illustrated as dramatic case report. So, a patient with congestive heart failure and pre-existing renal disease was found to have severe hyperglycemia. Because fluid replacement was contraindicated, the patient was treated with insulin. The insulin treatment resulted in shift in the fluid from extracellular to intracellular compartment, sufficient to ameliorate congestive heart failure. Now, the next complication is cerebral edema. Blood glucose concentration should never be reduced precipitously. Rapid reduction is the major contributor to the development of cerebral edema and fatal outcome. The exact cause of cerebral edema in the HHS is unknown, but animal studies suggest that the neuronal intracellular osmolality increases in the HHS. The osmotically active solute has not been identified. The term idiogenic osmole is used to describe these uncharacterized, osmotically active, non-diffusible substances. They draw water into neuron when extracellular osmolality drops as a result of intracellular movement of the glucose. This is followed by severe edema, increased intracranial pressure, and disturbed hypothalamic function. The next complication is thrombosis. Large vessel thromboembolic event are the important cause of mortality. Severe dehydration and the hyperosmolality lead to the reduced cardiac output and hyperviscosity, predisposing to the venous and arterial thrombosis. Use of low-dose apparent prophylaxis is recommended for high-risk patients. Now, regarding continuous glucose monitor use for ICU patients, numerous clinical trials have been and being conducted to investigate feasibility of continuous glucose monitoring use in ICU population. There is potential to facilitate more appropriate insulin delivery and decreases ICU length of stay, minimize hypoglycemia in this patient, but definitive validation of the accuracy of this device and feasibility for ICU patient remain to be done. The FDA approved the emergency use of this device during COVID-19 pandemic, which demonstrated early feasibility and the accuracy data for this device, which allowed for decreased point of care glucose testing. Thank you.